Hello, everybody. Welcome to a webinar. We have some real exciting panelists. So, Emily, would you like to start by introducing yourself and the exciting work you're doing at MercyOne?
Yeah, thank you, Dr. Grundy. Good afternoon. My name is Emily Fletcher. I'm an ambulatory care program manager with MercyOne's Population Health Service Organization. So my role is to coordinate our ambulatory program. So our RN health coaches, our community health workers, social workers, pharmacy, all those team members focused on care management within the clinic setting or the patient's community setting. And so our team has done a lot of work on the COVID-19 outreach. So I think I'm a few slides away. So, and I can hand it over to Dr. Porowski to introduce herself.
Hi, I'm Margaret Porowski. I'm a neurologist by training, but serve as the Chief Medical Officer for Catholic Medical Partners, which is an independent physician organization. I'm also serving as the interim CEO, and we negotiate the contracts for our doctors with payers and oversee a quality program that has significant financial impact on their practices.
And Jerry?
Hi, I'm Jerry Senni. I lead Orlando Health's value-based care and population health work, which is a portfolio of about 9 large payer arrangements, a Medicare shared savings program, 2 large direct-to-employer arrangements, including the one with Disney, which I believe is the largest in the country. And we're also actively involved in the preparation for COVID-19, and our effort is much more focused on the sustainability post-pandemic.
And I'm Paul Grundy. I'm the Chief Transformation Officer at Innovaccer. Until a little over a year ago, I was a Chief Medical Officer at IBM and the founding president of the organization that drove the concept of the medical home. And Jerry, Pam is a good friend of mine who's my counterpart at Disney, and she's really proud of what you do in that relationship. Kanav is our co-founder and our Chief Customer Success Officer at Innovaccer, and I'm hoping by now he's gotten off of mute or rebooted. Kanav, are you live?
Yes, I am. Thank you, Dr. Grundy. And I was having some issues with muting myself, but I'm back. Thanks for that. So, hi everyone, and thanks for joining this webinar. I think our today's topic is to figure out what providers are doing to fight the COVID-19 pandemic and adjust to the new normal. So I think with that, Dr. Grundy, why don't you start by telling us, what, according to you, has been the impact of COVID-19 on the healthcare providers?
I think this has probably had the biggest impact on healthcare delivery since Fletcher wrote his report in 1911, and perhaps Johnson passed Medicare in 1968. When I talk to my primary care providers out there, initially, their business volume was down to about 17% of previous business volume. They were really struggling. They were going from 0 to a few telehealth conversations to thousands in a week. I was just on the phone yesterday with the CEO of Northwell, the system that actually has the most COVID patients in the United States, and they've lost $1.2 billion. They've been awarded about $700 million, so they've sort of recovered about half of that. But interestingly enough, he was quite positive about this because he felt very strongly that this was driving the kinds of changes that needed to happen, to move away from an episode of care to proactively managing a population with data. So I kind of look at this as, no crisis should be wasted. There's a lot of changes that needed to take place. This is just driving, I think, a lot of those changes. It's just delightful to have this group of panelists to talk about that.
No, absolutely. And I think, Jerry, I would like to pass it on to you to speak about what's been your perspective of the impact thus far.
Well, like most healthcare systems, we've been, really hit hard by the financials. We're currently in a framework where we're losing several $100 million a month. although we're starting to see some recovery in Central Florida, and we're starting to see some return of volumes. In addition to the typical impacts that have been described, we've seen across our physician enterprise really a pretty mixed bag. Obviously, cancer and obstetrics haven't seen a blip. Things happen, babies are born. Cardiology is down about 20%. Pediatrics is down 60%, with a great deal of concern about preventative care and immunizations that are typically done in the summer, as parents are reluctant to bring their children into an environment they don't feel safe about. Although we're not big in this service line, dentistry has ground to a screeching halt. But other things that we've seen, we have the largest trauma center in Florida. Our trauma volumes are down 60%. People aren't driving stupid, and they're not shooting each other to the same degree. So that's, I guess there's blessings in the midst of tragedy. Other things, we've seen increases in domestic violence. We've seen increases in severe mental and behavioral health issues manifesting. So there's a lot of things that, as Paul suggested, are changing. They're likely to be durable. And clearly, we have seen our volume of telehealth services go up by a factor of almost 1,000. And so we're beginning to become more smart about how we re-engineer telehealth from kind of an off-the-side-of-the-desk enterprise to something durable. Last comment is there's a lot of conversations taking place with payers, and the commercial and Medicare Advantage payers are awash in money right now, as what has been devastating to the healthcare system, to providers of care, is profit to them. And they're in situations where they've actually got statutory MLR problems that are causing them to have to consider either refunds, increasing payments to providers, a whole host of strategies that they're doing, or reinvestments. So it is a repositioning of the industry that is, as Paul said, is both a blessing and a curse.
No, I think, thanks, Jerry. That's really helpful. And I think mental health and domestic violence, as you rightly touched, are issues that are submerged right now and need to come to mainstream. I completely agree. And I think a second point about virtual care, I mean, telemedicine is a starting point, but I think virtual care is gonna pick up, and we need to re-engineer that, which we tried to avoid in the past. So that's a really good point. Emily, you have been seeing this on the field in Iowa, and what's your point of view of the impact in there?
Yeah, it's been, as Dr. Grundy mentioned, no crisis should go unwasted, or should go wasted. So we have done a lot of mobilizing very quickly with our team members, and I am proud of the work that they've been able to do. One of the interesting impacts we've had is a lot of staff working from home in the care management realm, and so really being able to shift their work from, they've generally been in the clinic setting working alongside the provider and the care team. And now many of them are working from their home environment, and so trying to monitor productivity, trying to continue engagement, really focusing on staff burnout. We have a lot of team members that are working long hours. They're working with patients who have lost their job, lost income, are really struggling with the social distancing and the mental health impacts. So really making sure that we have renewed focus on staff engagement and making sure that they're not becoming burnt out, especially now that they're also isolated away from their colleagues. So that's been one of the interesting things that we found. We've also found that hospitals and health systems are collaborating much more closely with public health, with the government, with other hospitals within the state. And so I think that's another bright spot of the pandemic, is we've seen a lot more collaboration among healthcare organizations with other parties in the community.
And this is Dr. Grundy. I have a quick question. In Iowa, you guys did some work where you looked at hospital admissions for hypoglycemia, and like 82% of those were occurring in the last 4 or 5 days of a pay period. Are you seeing a surge in issues around disparities, around lack of food, that would cause hospitalization?
We are seeing, I can't speak to it from the admissions perspective, but we have seen quite an increase in social needs. Obviously, people are lacking both financial resources at this time as well as social support. And so we've certainly seen an increase in patients who are discussing fear and anxiety around the crisis, who have financial needs around medication affordability. We also have, which is interesting that I hadn't considered before, we're seeing as you have to do a lot more things online, we have some older adults who maybe don't have credit cards or debit cards and things of that nature. And so really trying to find services for them so they can actually get food delivered, they can order the supplies they need. We're also seeing those who may lack financial resources having difficulty. I would say it goes back to, I've been reading that social distancing is a privilege. Many people still are going to work. We have, the people who work in grocery stores and things of that nature. People are still using public transportation. People who have multiple families, generations living within a home. So I think we do have a focus on the fact that although social distancing is ideal, that it is a privilege and not everyone has that opportunity.
Okay. And Dr. Porosky, I mean, you have been working on the field in the red zone state of New York, not in the city though, but in the Buffalo region. What are your thoughts on the impact on the providers?
Well, we have over 60 different primary care practices who are on a variety of EMRs. They vary from older folks that are in solo practice to groups of young millennials. So how quickly they adapted to getting telehealth set up and working was very different between practices. A lot of them had to furlough staff because they had almost immediate cash crises. And of course, the staff that got furloughed were people like their care managers. And so trying to maintain the quality metrics that are a source of significant cash flow to them has been difficult. Some of them, the impact was obvious. We've been in lockdown since March 23rd. No one could get a colonoscopy, getting a mammogram done, getting vaccinations. All of these things were a huge challenge, but then more subtle things, trying to control blood pressure at a time when people are just freakishly stressed out, or trying to control a hemoglobin A1C and a diabetic who has to stay home all day and all they can look forward to is what they're going to have for dinner. So trying to get any of these metrics under control has been a real challenge. We've also had a lot of trouble for patients that still need to be seen in the office with getting adequate personal protective equipment for our providers. There's been a lot of price gouging. We were so short on hand sanitizers that we had one of our local distilleries making it for us. The availability of testing was nil. And pretty much for a long time, we only had enough test kits to test people that were actually being admitted to the hospital and first responders. And then with all the people not going to the emergency room, I wished I'd had ED visits per 1,000 as one of my metrics. What you had was a lot of people who were really sick not going. So that when we take a look at the data from our associated hospital system, admissions for things like heart attacks, strokes, heart failure, COPD, pneumonia are down between 50 and 70%. Well, I'm quite sure COVID did not cure all those illnesses. And that means that we've got a lot of people at home, not just that didn't go to the ED for trivial things, but who had had minor heart attacks, who had had minor strokes at home, that we're looking to identify so that we can do the secondary prevention that they need.
No, absolutely. There's a lot of catching up required. And I think that's one of the things that we want to discuss today as well. So thanks a lot for that, Dr. Porosky. And I see there is a lot of audience out here who's interested to interact with us. So I think what we should be doing now is starting a poll. I'll let the organizers start the poll right away. I think the question that we're trying to ask from all of you is, what has been the most troubling obstacle for your organization in the journey of providing care during the COVID-19 pandemic? I think we're trying to gauge 4 answers. Is it to communicate better with the patients? Is it to around your not having a central view of COVID? Or is it around remote patient monitoring? Or finally, triaging the high-risk patients to the right intervention? We'll close the poll in a few seconds. and then get back to what the results were.
This is Dr. Reddy. I think it's fascinating that our largest number is communicating better with patients. And I think that's so important because I think the two things we really need to focus on is, as physicians, is difficult diagnostic dilemmas and relationships, and that bodes well to the concept of relationship. What do others think?
This is Emily. I would agree. I think one of the benefits with communicating with patients is we have found that patients really want to hear from their healthcare teams at this time, and we do have patients often answering their phones with more people working from home. But there's also a concern about scams, and so we have a lot of patients who are fearful when we call that our outreach is not with the best of intentions. So that's has made communication a problem here at MercyOne. It's been more challenging to do that.
This is Dr. Porosky. We have a lot of patients who really liked hearing proactively from the practices. For visits, a lot of our older patients just could not figure out how to do the video component of the visits, but they were very happy to be able to talk to their providers. And we have a whole lot of patients who are planning to continue to communicate this way going forward.
So I happen to be a healthcare ambassador for the nation of Denmark. And I guess in some places the future is now. Over 80% of the encounters in Denmark are no longer face-to-face and have been that way for a number of years. But within about 2.5 to 3 years of really beginning to have the availability to commute asynchronously and commute remotely, we actually saw the number of face-to-face visits pop back up. We now have as many face-to-face visits as we did prior to this, but they're just more powerful. And I think that's what's exciting, is that as we go through this, that relationship, that need to have the human touch, I think will continue to surface. But we'll be able to use these tools to really in a much more powerful way, actually manage the patients more effectively.
Yep, and I think I should stop sharing my screen and start it again to make sure that you can see my presentation. I think while we get this figured out, the poll is really interesting because what it says is, triaging with high-risk members and telemedicine is something that, as we all heard, is providers are able to adapt and get used to it. It's the next wave of communicating better with patients in this new normal, and the current state is something that we are trying to figure out. So that really speaks to it. But I think the next place where we want to go to is, we have esteemed panelists from Florida, from Iowa, and from New York, from 3 different states in 3 different varying journeys of fighting the COVID pandemic. We would love to hear some anecdotal stories from you on how you have been fighting this COVID, some anecdotes and results you want to share on how you have been able to curb it. And I think then from there we'll go to some questions around the new normal and how would that look like. So Emily, would love to start with you. I mean, if you will start sharing your journey of MercyOne, and I know I've been deeply involved with your team on the social determinants along with the COVID-19. So would love you to share some lights about that.
Yeah, thanks, Kanav. So we started just a few days after COVID-19 officially was designated as a pandemic. We did some focused outreach with our patients that were engaged in chronic care management. So those patients that we were already working with very closely, and those patients with multiple health conditions, many of them older adults, and did a really focused outreach to them to make sure that they had everything they needed to safely practice social distancing or physical quarantine if necessary within their home, And it was both medical and social needs. So do you have all of your medications for the next 30 days? If you're on oxygen, do you have enough oxygen supply? Do you have a resupply plan? Do you have enough food and water in your home for the next 3 days? And then do you have a resupply plan? And so really digging in on each of those different factors with patients so that we could make sure that they had all the resources they needed within their home environment. And then a few days after that, so we did a really focused outreach, got a hold of most of those patients, and then we needed to expand. And so on this slide, you can see we have over 315,000 patients that are attributed to one of our value-based contracts. And so we needed a way to reach out to patients proactively, but of course we didn't have the bandwidth to reach out to that many patients with our care management team. And so we used the CDC guidelines that looked at age and different chronic conditions that would make patients most susceptible to have a severe illness if they contracted COVID-19. So looking at patients that were over 70 years old, those that had heart failure, diabetes, COPD, things of that nature. And that brought us back to over 15,000 patients still. So we needed to narrow it down a little bit more. So we used our predictive modeling that we used to identify high-risk patients in general. So looking at different conditions and how different factors play into each other. And then on top of that, we layered one more level to look at patients who have previously identified social needs. So as you mentioned, Kanav, we've been working together on screening patients for health-related social needs in our clinics. And so we decided to pull out a few of those social needs to prioritize patients. So looking at those patients who have reported previously that they've skipped medications to save money, patients who have stated that they often feel alone, and also patients who have were worried about food running out before they had money to buy more. So those are the three factors we looked at, and then we actually prioritized outreach to those patients before we reached out to other patients. And we spread that work across the board. So we had RN health coaches making those calls. We had community health workers who are non-licensed care team members, non-clinical, that really focus on the social needs of patients. And then we also had LPNs and CMAs making contacts. So we were making contacts across the board and then raising up concerns or delegating as needed to other care team members. And then after that, so we got that going and they've been working those different lists. And then after that, we started to expand our outreach. We've always made sure we manage the care transitions of those attributed lives. But we started to expand our outreach to any patient that was discharged from one of our MercyOne hospitals back to their community settings. So we were reaching out to those patients, asking those same types of questions, of course, on top of the traditional questions you would reach out to patients on discharge. So their red flags, what to watch for, do you have medications filled, med recs, things of that nature. And so we expanded outreach to them. And really for the purpose of we needed to have our hospitals as empty as possible in case there was a surge. So really trying to prevent any readmissions. We have very low readmissions in our value-based care groups. And so expanding that work was the next logical step. And then we've also are reaching out to all patients who are tested for COVID-19 at a MercyOne facility and then sent home to quarantine and making sure that they have those both medical and social needs met, and then continuing to follow them every 3 days until they recover or they have a negative test result. So that's where we are in our journey. I think there are some results on the next slide.
Yeah, can we move to the next slide real quick? Just one before. Slide 6. Thank you.
Thank you. So that was kind of the timeline on the left of how we expanded outreach. So of course, as I mentioned before, really trying to avoid staff burnout. So it was a lot of change in a really short period of time. We are lucky to have a system where we can update protocols. So we have these protocols which essentially serve as a guide for our care team members. So essentially if you ask this question, the patient responds this way, this is the recommended action. And so it really helps patient guide the care team member through, especially when there's so much change happening at once. And the results show the different domains we've been asking patients about, and then what our overall population of essentially screened positive for those needs. And then a greater split for looking at the patients who had previously screened positive for social needs. This was actually, I've been meaning to do the analysis, so I was so happy to be invited to talk about this today because it got me to actually look into the data a little bit closer, probably more quickly than I would have had the opportunity to do otherwise. And as you can see, the patients who have previously screened positive, so they're vulnerable for social needs, really did need that touch more quickly. They were more likely to be to have a resource need at this time. And I also wanted to draw your attention to the mental health needs across the board. We have seen a lot of fear, anxiety, stress around the situation, and also substance abuse, mental health, things of that nature really do need to be a focus of this outreach. And so, of course, we're also making sure that we have mental health support around our patients, and also that we're asking if they're in crisis. And I think that's important to make sure that your team members are comfortable assessing that and then getting them to the support as needed.
I think that's really helpful, Emily. And I think just a quick follow up on that. I think two things. One is, you guys just did not go towards the assessment and the outreach part, but you also went 2 steps forward in getting the social need follow-up in place. And I still remember working with MercyOne, like your readmissions were already as low as 11 or 12%, where the national standard is about 16, 17%. So you still wanted to go much lower on the readmissions to make sure that your beds are in sufficiently equipped stage if the surge comes in. So that's really helpful to understand how you have been thinking in Iowa. So thanks for that.
Thank you.
Hey Jerry, would love to pass it to you, and if you can move to the next slide from the organizer's lens. Jerry, what is your view in Florida and at Orlando Health? How have you been tackling with the situation? Jerry, you seem to be on mute. Sorry.
Apologies. So as a large 9-hospital healthcare system, we've had a lot of resources we've deployed towards this, and I would basically put them in 2 categories. One is the predictive analytics around the course of the disease, which is the more typical number of lives potentially at risk, inpatient capacity, ICU capacity, ventilator capacity, and then projecting the demand of PPE and some critical pharmaceutical agents that were in short supply. The second one, and I would say early on, our leadership began to focus on the recovery, even as we hadn't even begun to get close to the peak, and developed 6 major task force groups that grew across the system to focus on, first of all, becoming experts in COVID care, which was the best clinical evidence, not the latest popular evidence, but the best clinical evidence, and what we could do to become really best of class in treating patients. Secondly, helping to safely provide for our patients in recovery or ramp back up, which is, educating our offices, restructuring in 1,000 ways the way that our points of contact with patients evolve. Another one is on reimagining and the innovative models of the future, with those around the new normal expression, as do I, but I would quickly say that we were trying to say, how do we embrace those things with speed? Again, as you described, relying on new technology, new ways of interacting with patients, omni-channel communication with patients, a variety of approaches that are going to be durable, and also really challenging, the delivery models that we have in place, from the size of our hospitals to the service spectrum we offer. Another task force was looking at our capital expenditures. Just like your 401k is now a 201k. Same thing happens with us. Our investment returns are not what they were. Our cash has been depleted by the operating losses. And so we had a 10-year capital plan that we've had to totally recast and revisit. Another team was looking at our IT. We're in the middle of a major EHR conversion, and we've had to reprioritize some of the timing of that because so many resources were drawn into the COVID fight. And finally, we have a major effort to try and help Central Florida businesses, including Disney, Universal Studios, and others, allowing them to reopen safely and get back to business as soon as we can. From a frame of, and we can go to the next slide, Central Florida has been relatively blessed in terms of COVID impact. While we have lost over 1,000 souls during this challenge, the nature of the community, it's relatively low. It's over 3.5 million people, but relatively low density, relatively limited mass transit. So we always hate cars, but it at least allows you to travel in a secure environment. The level of social compliance of the community, for whatever reason, was very high. People wear masks everywhere, and the businesses were relatively compliant. And lastly, government intervention was prompt, early, relatively aggressive, and seems to have been fruitful. Last thing, which I've got to give kudos to, really Disney. They shut the theme parks hard closed 2 weeks before governments intervened, which by any best speculation probably saved thousands of people's lives. Because if you have 260,000 visitors a day going through the turnstiles and then traveling all over the world, it would have been just a petri dish of exponential growth that was somehow they had the business courage to shut that down early. So on some of the things that we've highlighted on this slide, what we've done in terms of managing our population have been mentioned by Emily and others. We reduced our telemed offering to 0, intervened very early with Disney in terms of the shutdown, but also helping them with the recovery. And then basically all the connected elements of care that are essential to link ourselves to our patients, but also help them with the recovery process.
Perfect. Thanks, Jerry, for this. This is really helpful. And I think you're absolutely right. Taking that courage of closing 2 weeks before is a big business courage from Disney, and your collaboration with them to get them back on track is again really appreciated.
Right. Aside from the leadership, they recognize too, Disney has a very large China presence in Shanghai, so they knew firsthand on the ground that things were going sideways early, and they acted. They were telling their colleagues that this is legit. It's going to get away from us if we don't do something.
So it's a really valid point. All right. And I think, Dr. Porosky, Catholic Medical Partners, a group of independent practices. So how have your organization been dealing with that? Would love to hear something on that.
Well, our major job has been supporting our providers. As you can see, we have over 60 primary care practices, but double that number at least again of specialty practices. And they were so busy just trying to stand up telemedicine and take care of patients that they did not have time to be searching for all sorts of other sources of information. So one of the first things that we did for Catholic Medical Partners is set up a COVID website that basically had all the information that they needed from multiple sources, and set up a weekly town hall meeting where they could meet with the Commissioner of Health for the county, with CMOs from different payers, with our Chief of Infectious Disease, to literally get the information from the horse's mouth. We were sending out daily updates on changes the Department of Health was making in who could be tested, what quarantine procedures were, when could healthcare workers be released to return to work. And so there was just a lot of information that we were gathering up and flowing to practices. But probably the main thing that we were doing is making sure that our providers got paid. Everyone has multiple different insurance providers that they deal with. Prior to this, there had been very little adoption of telemedicine because there is a lot of capitation, and telemedicine was considered as being covered under the capitation. And so there really wasn't a lot of impetus to put the effort into developing it. Now, working with the payers and getting them to pay for telemedicine services where they hadn't before, getting them to pay for annual wellness visits, looking at what rate we could get even if a physical exam couldn't be done. Naturally, every payer did something different from the other. They did something different for the primary care doctors and the specialists, and they changed their minds about what they were doing at least twice a week. And so being able to get the most up-to-date codes out for each payer without the poor provider having to go into every portal for every piece of information, they found an extremely valuable service. With risk contracts, interestingly, because if you have a risk contract that's primarily looking at cost of care with no elective surgery, the huge reduction in utilization of hospitals for things like stroke, MI, Many of our providers stand to do very well in these contracts, even with adjustments made for some of the quality gaps. And we had two major insurers say, oh, we know you people probably don't want any risk, so we just won't have a risk contract this year. Say, you've got to be kidding. This is the one place our providers are probably still going to be able to get money. We had one provider who initially stepped up to the plate in what seemed like a very enlightened gesture. Our primary care doctors had a good part of their income capitated, but then they were separately able to get fee-for-service payments for things like transitions of care, med recs, annual wellness visits, or Vaticas. And they said, look, we know you're struggling to get these done, so we're going to take your average monthly fee-for-service from last year, and we'll pay you that every month on an emergency basis, regardless of what you're able to actually bill. And they said, we'll do that on a month-to-month basis until you're able to get back to what your normal office practice would be. Well, after 2 months of emergency billing, they said, you know what? We're going to do this the rest of the year. And if you don't sign an amendment accepting that, we're going to retrospectively reconcile March and April. And it was like, you've got to be kidding. There was no way our pediatricians could afford to do this because their rate from last year didn't include increase in costs in vaccines, the increased number of vaccines that people were supposed to get. Basically, it was a very sneaky way to completely capitate the little piece of fee-for-service that they still had. And so an awful lot of the work that we are doing is trying to make sure that our providers are fairly compensated. We did get all the information out to them on things like Paycheck Protection Program and things where there was sort of a race to get the money if they were going to be able to protect their practices. And again, we have a lot of onesies that are older providers that we can't really afford to have be put out of practice because of COVID, or we're not going to have enough primary care providers in our area.
And
That's a
Dr.
really
Bur-
good. Go ahead, Dr. Brandy.
The little things are really important now as many of us are stuck at home. And I noticed on television yesterday that the consumption of buffalo wings are up 168%. So I want to thank you in Buffalo and the Anchor Bar for inventing those.
And that's probably why we have so many heart attacks and strokes. But if you want to eat well, come to Buffalo.
Sure, I think that's a good gesture. I think one thing you spoke really well about, which we are seeing in all walks of life, is over communication is becoming so important. I mean, we used to see colleagues and employees like talking in the hallways and sharing notes, and it's not the new normal. So we need to do town halls and communications more often than the other. And I think that's a good value add that you just mentioned there. So thanks for that. So I think we want to segue towards what's next. I mean, we have been, working relentlessly for the past 3 months and trying to, have sleepless nights and make things normal. But there is a new normal. So I think the first question that we have, we'll move to the next slide, is what is a new normal? And I think before that, we would like the audience to just do a next quick poll on what do you think going forward you need from technology to support you in the new normal of COVID-19 pandemic. So while we're having the poll, I think the panelists would love to engage with you and figure out like some anecdotes on how embracingly or difficult was it for providers to embrace the new technologies in virtual care, like telemedicine and remote patient monitoring. What has been your experiences on that? I think, go ahead, Jerry.
What we discovered is a couple of things. One is when you have high velocity, speed of embracing it, you learn a lot as you go. One of them is that some providers are really good at telehealth and some are not. And we've begun to say, as a large group of physicians, can we basically begin to reshape that and have people that are good at office practice, post-recovery, focus on office practice, and those that are really good at telehealth be able to do that. Secondly, we're reshaping schedules very, very quickly telehealth is not a 9 to 5 proposition. It's got to be certainly extended hours, if not 24/7. So we've begun to talk about different types of scheduling. We're discovering in a positive way that we can be more accommodating to providers that perhaps have disabilities that limit their mobility or ability to work in a more structured setting, are able to do telehealth effectively. We're also finding people that have family situations, perhaps an elderly or ill parent, somebody else they're watching at home, that are able to accommodate their schedules. So once again, we're finding that there's rays of light here in the midst of all this.
Yep, that makes sense. And Dr. Porosky, Emily, do you want to add in that while we have the poll live?
Yeah, basically, I think that telehealth is here to stay, but it is not a one size fits all, as well as some providers being much better at telehealth than others. Some patients like telehealth much better than others. We have found particularly people with young children who don't want to drag 3 kids on the bus to a visit like telehealth. And we're finding a lot of older people that have a hard time getting, a ride in. Are adapting to telehealth and actually like it. And so I think that it will probably be used selectively going forward, but certainly a heck of a lot more than it was before COVID. I think the other thing that providers are going to insist on is being compensated for what they do. So if you're a primary care physician who is capitated, certainly a telehealth visit during regular business hours that replaces a face-to-face visit would be under capitation. But to think that primary cares are going to provide 24/7 telehealth visit without any compensation after hours is not realistic, because for a long time the payers have separately paid doctor on demand or teledoc. Lawyers, accountants have been billing for, thinking about you while they're in the bathtub for years. And I think a lot of physicians are just sick of giving their services away for free.
No, that's a good point. I think selective patients and selective doctors will do better. And we see a very mixed response on the poll on the technology people need going forward. I think they need all of them. And of course, virtual care and remote patient monitoring and outreach comes to the top, which resonates to our previous poll that they need better patient communication and more virtual. That's making a lot of sense. I think we have about 15 minutes left in the webinar. We'd love to go forward with the next questions, which I think people are anxiously waiting on to hear from all of us, is how does the new normal look like and how do we prepare for that? So I'll let Jerry start with you. What do you think will be the new normal when the lockdown stops and people are back on the streets?
Well, let me speak just a moment about the trajectory of it. Everyone's described that there won't be a V-shaped recovery. It won't come back as fast as it did as it went down. We've gone through some projective looking at local economics, local employment. The biggest concern that we face in the near term, given the economic dependence on the service industry, is the loss of employer-based healthcare. That there will be a lot of people, the population will be here, they will get sick, but they may not have access to, as a result of losing their employment, they won't have access to healthcare coverage. Like most healthcare systems, we're heavily leveraged against our commercial book of business. Medicare is barely covers cost. Medicaid in Florida is horrific. So as a result, we're very dependent on a small number of employed patients, and are very worried about that. We see that the recovery is going to be not linear, but rather will be a gradual curve, but will reach an asymptote, something 15 to 20% less than what it was pre-COVID. So that's roughly our scenario economically.
Okay. And Emily or Dr. Porosky, do you would like to add on that?
Sure.
Yeah.
We have Wentwood elective surgery start again. And basically, we have already started elective surgery. Our hospital system, Catholic Health, has 4 physical campuses. And the minute that this became a threat, we designated one site as our COVID hospital. And so when patients, we closed the emergency room at that site. The other 3 hospitals have their EDs open, and we acquired Cepheid's rapid test so that if a patient came in and looked like they had COVID, we were able to tell them in 45 minutes whether they had it or not. And if they were COVID positive and needed hospitalization, we shipped them over to our COVID hospital. So we were actually able to aggregate our patients. Right now, in our 3 non-COVID hospitals, 2 of them have 0 COVID patients, 1 of them has 1. And so we were able to reopen elective surgery earlier than the other hospital sites in town. And we have gone through an elaborate process to make patients feel safe. They have a guide that takes them in, pushes the elevator buttons for them, opens the doors, so they literally don't have to touch anything. One of the big things that we are dealing with is patients who are scared to come back. They're scared to come to the ED because they're afraid they're going to encounter sick people. They're scared they'll come in for elective surgery and end up dead. And so I think we're going to see a persistent, real interest in sanitation and fear of infectious disease that perhaps our populations were much more cavalier about.
Enough. That makes sense. And Emily.
Yeah, thanks, Kanav. I'm really hopeful, I guess, and my optimistic side is I hope there's increased focus on mental health outcomes. I hope there's increased focus on social needs. We're going to have a lot of people who are going to be lacking certain resources throughout this pandemic, and it's going to continue throughout the pandemic. So I hope there's renewed focus on that. I hope there's more collaboration with education. We're seeing a lot of children at home right now, a lot of children that are not getting their school lunches, all of those things of that nature impact health. So I'm hoping we have a continued focus on where our patients are living, where they're working, where they're playing, and the health in those fields. I'm optimistic that there'll be increased focus on self-management support. As both Jerry and Dr. Porosky said, we have patients who are not coming into the clinics as much, and we've always known that access to good quality care is only 20% of someone's health. And so I really hope we can continue to focus on how our patients manage in their home environment, in their community setting, since we will have patients for a long time that will not be coming into the clinic. So while we're using telemedicine and different tools to make sure they still have a touch with the healthcare system, I hope we continue to work on self-management. That would be my hopeful perspective of what the new normal looks like.
So I think what we're hearing is that access to care needs to be solved with more trust and safety with the patients to come back in, and we will find innovative ways of organizations doing that. And at the same time, public and community health will become mainstream focus, which we always wanted for some time. But thanks to the silver lining of the pandemic, it's going to come mainstream now. So
I'm hoping so.
yes, no, thanks for that. I think if we move to the next slide, I think the next question that we have is, there's a lot of catching up required for value-based care organizations. We missed annual wellness visits, we missed preventive visits, as Dr. Porosky said. It's not that people are going to get cured by themselves. So, what are your views? I'll start with Dr. Porosky. What are your views on the catching up that you need to do, and how are you planning that?
Well, in terms of catching up, we know that for proceduralists, our GI guys are dying to do colonoscopies. And so they're going to be willing to offer Saturday hours. I'm willing to bet they'll be offering Sunday hours by the time we're done in order to recover the volume that they didn't get to see for the past couple of months. For annual wellness visits, we were finally able to persuade all of our local payers to accept a telemedicine visit that had audio and video. But obviously, you still have to get people in for their labs. You still have to have certain aspects of physical exam that require being done in person. Another thing that we're looking to do is to see if we can get HEDIS to catch up with the times and, for example, accept a blood pressure that's recorded by a patient on a video visit where I can actually see them taking the blood pressure. That ought to be able to be recorded and not require that it be an in-person visit to record it. And I think that, again, we're just going to be working long and hard, not just catching up in terms of getting the metrics, but getting patients back on track. So again, our poor diabetics that could only look forward to dinner, getting them out more active, back on the correct diet. For patients that were, didn't go to their pharmacy to pick up their medications, to get them back to being compliant with the drugs that they need to be on.
Right. And Emily and then Jerry, follow up.
Yeah, I second everything that Dr. Borowski said. I think we have really moved to annual wellness visits, telehealth, and I think that has been a huge blessing. Previously, for Medicare, their originating site had to be a facility, and so we weren't, it was really only geared towards rural communities where you would be doing telehealth in that nature. And so we have been able to expand that now that the patient can be at their home and do the wellness visit in that regards. So making sure we're getting those depression screenings done, the health risk assessments, the fall risk. I mean, all of that's challenging. You can't really do a timed up and go for fall risk with a patient at home, but you can still have your patient showing you their medication bottles. You can go through those medications with the patient. You can be checking on their mental health. So there is a lot of value for annual wellness visits in a telehealth perspective. And then with preventative quality measures, with things like colonoscopies, we have to have enough, test kits and things of that nature to be able to clear patients for COVID-19 before they can have their elective procedures. So there's steps in the process, but I think we are getting back to that.
Okay.
And the other thing that is part of our redesign that's underway right now, and it's more theoretical than practical, is rescaling the delivery sites of care. Let me be more specific. A lot of our 1- and 2-person primary care offices are just not economically viable anymore. While they have desire for autonomy, I get it, and they may be serving difficult communities. We're seeing a large effort to try and rescale those practices into fewer, larger, more concentrated economic models that have a chance of success. The same thing on the side of care side. We're seeing we're focusing now on reshaping everything from primary care, urgent care, convenience care, freestanding emergency rooms, and really rescaling the way that those are being designed right now, as people are looking for different points of access.
Got it. That's really important. I think we saw some questions from the audience, which kind of relates back to all the thoughts you have been saying, but I think are double clicking. So I will ask those questions together to make sure that we can address them in time. I think the questions are revolving around how do you make patients and providers prepare for telemedicine experiences better? Like how are you encouraging patients to do telemedicine better? How are you giving some guidance or tips or resources to providers to do telemedicine better? Like what's been your experiences around that?
This is Emily. We have done a couple things that I think are a little bit unique. We had one of our team members who's participating in a study, a fall study, where they were working with patients, and they actually created a YouTube video for their patients that was very basic, and it walked through the entire process of what a telehealth visit would look like for a patient, so they could see this is how you log in, this is what a waiting room is going to look like, this is what the encounter is going to be like. So they could really see the experience. It was really geared towards those who have never done a Zoom encounter and things like that. And we're also trying to do warm handoffs. So when our care management team members are working with patients, so when they're calling them on those care transitions, when they're reaching out to just check in on them, and the patient has a concern, they're actually scheduling that telehealth visit for the patient so that they can answer any questions and really walk through the process of what that experience is going to be like. So that's been helpful for us. And then from our provider perspective, it's really been the only option. And so I think it's kind of been, you have to adapt. And so we've had been piloting it for a long time with a handful of providers. And so they've really been the provider champions. So that peer-to-peer conversation has been helpful for us as well.
No, that makes sense. And I think we are almost up on time. So I think the last question and the next slide, if you move forward, that we wanted to touch upon really fast is we have seen some reliefs in terms of HIPAA waivers and COVID-19 patients' cost won't be counted in the benchmarks for downside contracts, and the quality reporting getting pushed by 2 months. What other reliefs do you want, or do you expect that's going to come our way?
Well, I think probably the thing that the practitioners have liked the best about COVID is relaxation and a lot of guidelines that they find not helpful to trying to practice medicine. But for quality reporting, I am really hoping that CMS is going to relax their expectations this year. As you know, payers that get 4 stars or above on their ratings get 5% more in quality dollars, and programs like ours rely on those payers to share the dollars with us. And so I hope they're not going to hold people to a metric that can't possibly be achieved in this particular scenario.
Oh, perfect.
One of the things that I found that will really benefit our rural communities is the ability to stay in the basic track for the Medicare Shared Savings Program for an additional year, which will really help our communities who are not ready to take on downside risk. With COVID-19 pandemic happening, they really have had to focus on that and not really preparing to take on additional risk in the coming year. So that's been a really huge benefit to some of our more rural communities, is to be able to stay in that basic track.
The last thing is we've done a poll of several different actuaries across the industry, I think 6 in total. And we actually anticipate for 2020 that our performance under our ACO arrangements and our risk contracts will be very, very favorable. There may be a rebound effect later in the year as unmet healthcare needs start to blow up again, but we're suspecting that this will be a windfall year.
What we don't want to see is this year used as a baseline for expectations in 2021. It is a statistical outlier, I am sure, more than 2 standard deviations from the mean. So to expect us to beat this year in terms of healthcare costs when people had such severe limitation to surgery and were afraid to come in for a lot of serious conditions is going to be a farce if they insist on it.
Yeah, absolutely. I think as I'm hearing some organizations who are trying to figure out what to do next year, that this is one of the most important points coming up as a contention. So let's wait and watch how that turns out. I think we are up against time, but I would like the esteemed panelists, Jerry, Emily, Dr. Porosky, thanks for coming up, Dr. Grundy for adding the insights to this. And I know as we have been working, I have been seeing all of you working closely, working tirelessly for the past 3 months, getting, and from Innovaccer, we have been trying to do our best to give you the right data, the right workflows, and the right interventions and telemedicine to get to where you can help your patients. So thanks for joining in, and thanks for giving us the perspective of what the new normal might look like and some anecdotal hacks to how are we solving this together. And to the audience, we will be continuing our webinar series. Please subscribe to careas1.org to learn more about our next webinars, and we look forward to the next one soon. Thank you all.
And to the audience and panelists, I'm so proud of all of you for what you've been doing on the front line. You've been amazing. Thank you.
Yep. Thank you.